choice, and that they are trying to make it sustainable through training more professionals. We know that a supportive policy environment is the first stepping stone to scaling up and its sustainability. And here, it was clearly apparent that yes, that is there. They were very clear at all levels that both management as well as technical, that the policy is very clear. It outlines that all reproductive age people have to have access to different contraceptive methods, and it is their right to choose and use a method based on information. The caveat there is resource allocation to the YFS, youth-friendly service and reproductive health services of young people, is limited. So these senior management, both management and technical folks, are very well aware of what the policy says on the one hand, but also on the other hand, the resources, availability of resources at their level. So, and this was translated even further by the senior management at the district, Wareda district level. He says that it is unthinkable, cognizant to the critical shortage of the financial resources, it would not be possible to allocate budget for specific services like family planning. The allocation would be for overall prevention activities in the Wareda. And really, reading this now, after a period of a few years, specifically after the aspect of both COVID as well as the violence, this really stands out that there is reproductive public health prevention activities, but those resources are minimal and a lot of juggling has to be done to really see that those are all directed to where the need is most. Investing in youth-friendly services for family planning, reproductive health. This was a very specific question we asked them because we wanted to know from their perspectives, the stakeholders' perspective at various levels, what from their perspective is the aspect which goes into investing in youth-friendly services. There at the federal level, there is a proclamation or a decree that indicates that each health facility needs to mobilize resources itself and allocate budget for the services they want to strengthen. So there is this aspect of independence, but the independence is also marred by what they want. And if at the facility level, they want to invest it on activities related to strengthening LARCs. On the other hand, in another region, Amhara, the director of the health center says, I don't know any investment to the strengthening of LARCs at the YFS unit. So when you read this, okay, what is really going on? Where is the bottleneck happening? And why is this bottleneck happening? So we delved further into what is the quality of family planning services, okay, both counseling and service provision. On the one hand, REST, which is the NGO which was supporting its own health centers, said the young clients do not want to be served in rooms other than the YFS unit, much more for the sake of privacy, but there are the constraints, the health system's constraints of staff turnovers, interruption of services, as well as having a unlimited supply of LARCs. data availability and use. This is within the Ethiopian system. It is a devolved system. So you have a lot of the programs are conducted at the regional level and at the district level. And at the regional level and the district level, at both levels, they have quarterly meetings, which they call performance review meetings, where they discuss everything based on the data that they generate from the health centers. Okay. And as the senior technical staff from Tigray said, this data that we get is useful for planning and decision making. However, the format that they currently have doesn't have the age disaggregated data for method use. Because they don't have that, then at the regional as at the district as well as the regional level, they are in fact unable to really state whether there is an increased uptake in LARCs by the 15 to 24 year age group. Now, on the other hand, if you hear the director of the health center, they say the young people are now seeking service, the uptake of LARC has increased, the increasing awareness and change of attitude towards LARCs are achievements that he has seen within his own health center. Again, we take two steps back and look at all of these different information, qualitative information you're getting from all of these from all of these various levels of health service delivery from the prevention aspect, and you say, something is happening. I really can't understand, I'm getting conflicting information. What's really happening? How can I disintegrate this? And how can I, in the disintegration of this, really help and facilitate at the sub-district, district, and the regional level to help the program managers, the public sector program managers, to implement a program that, though they are committed to, is really not achieving what they really want to achieve, which is increasing contraceptive prevalence among young people, including that LARCs is available and acceptable to young people. So, as I said, we did the qualitative, which was the meat of the whole study, but within that we wanted some really rigorous data, and for that we collected data from the family planning folders. And the way we did this is, as I said earlier, we had 4 centers in Amhara and 4 centers in Tigray, which we collected data from. And the before is the data that was collected 6 months prior to the LARCs training. So the LARCs training really happened between August and September. And so we collected data 6 months before that. The training happened, and the training was staggered over these 182 health centers. And then we collected same data 6 months after. So that 1 month where we did not collect any, we collected data, but we are not reporting it. What we saw was that it was only in 1 health center where there was a significant change in the number of LARCs as compared to the number of in LARCs before, 66 before and 37 after. Okay, so that a change was 37.1%. Okay, and in Tigray, it was the same, 15.2% to 33.8%. These were the only two sites where there was statistically significant differences. And we were able to go back and identify the technical and management interviews that we had conducted, the health centers, so that we could relate that to these health centers per se. And in that way, we were able to disentangle what happened, what transpired in these two facilities, the Health Center 4 and Health Center 4 here in Amhara and Tigray, as compared to the other sites. One of the salient features, particularly in Health Center of Tigray here, for one, was that many of the young women there were going for jobs in the Middle East, and they wanted a long-acting contraceptives. With this influx, with this training and the implementation of the training, they came in and opted for LARCs. So those were really important, significant findings that we could then identify why in facility health centers 1 to 3, there wasn't much of a difference, or there was in fact, a fall in the percentage of acceptance, whereas in others it was just very little, 10.2 to 11.1. So in conclusion, so one of the aspects is the service delivery model was scaled up to 182 additional YFS facilities. The Ethiopian government continues to remain fully committed to improving adolescent youth sexual reproductive health, but scaling up implementation is fraught with major challenges. Okay? And it's really, not only within the family planning, availability of a range of contraceptive services, but in many other preventive public health implementation programs where you want to go, where you've tested a model and within a program you want to scale it out, when the donor funds are not there, it really is the limited financial resources, the limited public financial resources. So without an obligated budget line item for YFS included in regional Vareda and health center budgets, challenges to sustaining and scaling up remains. On the other hand, even if there is financial resources, if the overall health systems are weak because of human resource shortages, staff turnover, quality of care issues, the infrastructure, if the buildings are, in deplorable state, people will not come. Particularly young people will not come to attend the facilities there. And data availability and its utilization of the data hampers sustaining and further scale. All right, I'm done now with talking. So, are there any questions? These are the sources. And by the way, the retrospective assessment has also been published, and the aspect that I found most interesting was that at the national level they have regional at the federal level they have a research team, and the day this paper was published, I got an email from the head of the research group at the Federal Health Center that they wanted us to come and present this. And we were all ready to go and do that, and COVID hit. So part of the downstream effects of COVID. But I think now that it's COVID they are grappling with many other problems than the adolescent youth-friendly service in Ethiopia, but they are still continue to be committed to improving their adolescent program. Thank you.
Thank you very much. So anyone who has a question, please feel free to either put it in the chat or just go straight ahead with your mic and ask. Thank you so much, Dr. Fikri.
You're welcome.
I see some virtual hand claps there as well. So thank you. I see a hand up and I don't know whose it is. Oh, Dr. Whalen has a question, looks like.
Yeah, Fariel, thank you for that very interesting talk. I know a little bit about Ethiopia, but not a lot. And I seem to, my work, as you know, is in Uganda, and I see so many parallels. I wonder, did you interview the actual women who receive the contraceptive just to sort of get a firsthand information about their acceptance, and did it meet their expectations? Information about how, whether it allowed them to work more or improve their well-being.
Thanks, Dr. Allen, for that penetrating question. Yeah, no, we did not include among our key informant interviewees women who received the service there. However, what we did get is the information about the utilization of the youth-friendly services, and that utilization was pretty high when it were particularly because these young women would not like to use any services, and it wasn't limited to LARC services, any reproductive health services in the general clinic, because they felt as if it was a stigma for them.
I guess the follow-up question I would have is, what the male partner in the relationship role might be in the acceptance or use of the contraception.
Again, a great question. Okay, now this, we in the scaling up, in the retrospective assessment of the scaling up, we didn't interview the peer educators, but in the testing of the model, we did. And from there, from the information gleaned from the peer educators there is that the men, again, men within this age group, 15 to 24, they were very embarrassed to go with their partner, okay, to the main clinic for reproductive health services. But they were much more willing to go to the youth-friendly unit for the family planning services, including LARCs. The dilemma for the men was they had a lot of misperceptions about the effect of LARCs in the context of fertility, resumption of fertility after the 3-year period of LARCs. And one of the roles that we had trained the peer educators in the counseling was about the return to fertility. But no, we didn't interview either the women or the men who utilize the facilities.
Okay. Other questions, comments?
I had a question.
Yeah, of course.
I was just wondering about sort of, I know from the interviews, you reported some information about the management and then the technical staff at the health centers that you were studying. And a lot of what they were talking about was funding. And I just find it interesting that this age group that the program is targeting represents a pretty large fraction of the population. But at that management level, people aren't seeing that warrants the funding, right? A couple of the responses said the funding should go to more, pressing health issues. And I was just wondering, like, how can you work with that thinking? Like, because I know part of your work is the research, but it's also working within those government offices about changing that thinking.
Absolutely, Paula. That is just one of the biggest challenges. And the country director of the Integrated Family Health Project, I always have a big smile at my face when I hear him talking, because he begins by saying, stating, no, I wouldn't say he begins. In his talk, he always mentions that the need for preventive care and the need for family planning. And he puts it in the fact, he puts it in a very unique, I think, Ethiopian way, because he puts it as he himself, uses contraception. And then he asks the audience, who are all, adult men and women, whether they use, and not only whether they use, and they say yes or no. So he then pinpoints and asks them why yes and why no. And that is he does that at all levels. Because then the first time when he did it, I went and I asked him, I said, Mengi, why do you do this? He says, because that's the way Ethiopians only understand. I have to bring it to their level. I said, okay. Yeah. So, however, he's a very well-respected public health person within Ethiopia. But he recognizes these challenges, and he said, if we don't continuously do this, we will lose out. Our country will lose out. So it's like you need champions like him and more than one person in many countries in the developing world for many aspects to be able to improve the health conditions.
Great. Fariel, there's a question in the chat that somebody just dropped. Milena has, I think that would be our last question, but please, if you'd go ahead and help us answer that. Did you see that, or do you need me to read it? Milena, how about you go right ahead and open your mic and ask directly if you're still there.
And Milena, also, from which region are you originally from?
Okay, you got it.
Yeah. Is Milena talking, or should I answer?
Yeah, she probably is not answering.
Hello, can you guys hear me? Sorry,
Yes,
I'm at work.
yes. Yeah.
So I'm from Tigray, which is like the northern region of Ethiopia, and there's like a war going on right now. So I was just thinking, like, this was a really great model. Excuse me. model, and I think now more than ever it would need to be implemented once like the humanitarian corridors open and like NGOs can get into Tigray, because a lot of the women have faced violence and sexual violence and need medical attention. So I was just wondering if you guys ever had plans of like doing this again.
Okay. Absolutely, Melina. Okay. But let me add some caveats to that. It will not be as a research program. It will be implemented in Tigray as a program implementation. So the careful data collection that is done as part of research will not be there. But I think your question was much more related to at a program level, and absolutely. Unfortunately, during the violence, the team, the country team were unable to go to Tigray. But now that the things have quietened down, they are beginning to implement the program.
Thank you.
And at another level, you brought up the issue of sexual violence, and they are also going to be implementing aspects within the sexual violence paradigm.
Thank you.
Right, I think that was our last comment. We are right at the end of our hour, but thank you so much, Dr. Fikri, for being able to come virtually to speak to us about this very interesting topic and program that you've been working on. And we have truly learned and enjoyed you sharing your work and experience, and definitely for the students, I'm sure they've learned something. I have sent my hand clap, and please in thanking Dr. Fikri today for that excellent presentation.
Thank you. Thanks a lot. It was a great pleasure to present.
Thank you so much.
Bye. Bye-bye.
All right, thank you all for coming, and please come again in February. I saw the dates, and we'll send out an email announcement and reminder for the next seminar.
And also spread the news to 2 other people that weren't here today.
Yes, each one bring one.
No, 2.
Each one bring 2.
Yeah.
Or more.
Yeah.
Yeah. All right. Thank you so much, and we'll see you next time.
Thanks a lot. Bye.
All right. Bye-bye.